This is PopHealth Week on Healthcare Now Radio. I'm Gregg Masters, Managing Director of Health Innovation Media and the producer co-host of the show. Joining me in the virtual studio is partner, co-founder, and principal co-host Fred Goldstein, President of Accountable Health, LLC. PopHealth Week engages industry leadership and stakeholder voices spanning payer, provider, patient, vendor, and regulatory communities in population health best practices and strategies. To create private label thought leadership content, connect with us at www.popupstudio.productions or follow and direct message me on Twitter via @GreggMastersMPH, and that is Gregg with 2 G's. On today's episode, our guest is David B. Nash MD MBA, the founding dean emeritus and full-time faculty as the Dr. Raymond C. and Doris N. Grandin Professor of Health Policy at the Jefferson College of Population Health. His national activities, including curator and master of ceremonies for the annual and quite popular Population Health Colloquium, now in its 21st year. And with that introduction, Fred, over to you.
Thanks so much, Gregg. And David, welcome to Popular.
Thanks. Great to be back.
Yeah, it's been a number of times on the show, so it's always great to discuss something. And you've got this new book out, which makes it even better. So really appreciate you coming back on. So let's talk about how COVID crashed the system by you and Charles Wolforth. So tell us a little bit about why did you decide to write this?
Sure. So Charles Wolforth, I met Charles in the fall of 2019, pre-pandemic, at a great meeting in Midtown Manhattan. Seemed like a super nice guy. Told me he was a science and medical writer. Take his card, and we had a meal together. Didn't think too much of it, other than a nice guy. Of course, that was, let's call it November of 19, and then 2020 and March. And so spring of 20, Charles reaches back out to me, Fred, and says, "Hey, remember me?" And of course I did. He said, "Listen, you've got a great voice and I'm a great writer. We got to get together and tell this story. Nobody's telling the story." And my first reaction was, oh gosh, I got a lot to do. Do I really need to do this too? And honestly, Charles was very persuasive and super articulate guy. And he said, "Look, don't decide today, but I really think that you could fight COVID with a book." And I thought, wow, okay, I hadn't really thought of it quite that way. And at that point, Dr. Esther Nash and I were more worried about our daughter on the front line than I was about writing a book. But Charles said, that'll be your contribution in part to the battle. Okay, so a couple of weeks later, I said, okay, what do we do now? And, I've written a lot of books, more than 24, but they're textbooks and not the kind of book you go to the, bookstore to buy. Anyway, so we had to find an agent, write a sample chapter and a detailed outline, fill out the whole author questionnaire. And our agent was wonderful. She shopped it around. We got to Roman and Littlefield, a very well-established house in Maryland, got the acquisitions editor. And then basically it was then a race to the deadline, which was December 31st, 2021. So we spent 9 months every other week on a 90-minute Zoom call. And I did all the outline with Charles, and then every call was focused on a chapter. And I have a great medical student who helped me, Zach Goldberg. We had over 400 references, so it was a crazy process. But the why was I'm going to use my big mouth to write another book to tackle COVID instead of trying to fight at the bedside, which clearly I'm way too old and out of shape to do. So that's the punchline.
Well, I love the fact that you said you're using this to tackle COVID, because you're actually taking on the entire healthcare system.
Well, as you know, and it's so great to be back on this wonderful program, it's all about systems thinking, right? And given what was going on in the background with the 737 MAX, and then that New York Times bestseller about the total duplicity on the part of Boeing, and my work with guys like John Nance and others. And I thought, basically, this is just a giant plane crash, and all these people are dying every damn day. Just imagine if a 777 went down every day at Philly International. I mean, we would close it all down, and we'd ground every airplane until they found, whatever 3 pieces were broken. So that's how we came up with the crash scenario and the NTSB investigation. And as you know from the book, I mean, there isn't really a black box, but it became evident what the black box would have contained, right? And for guys like you and me, no real surprises here. Obviously, this plane was doomed on takeoff, right? And then we spend half the book about what a disaster. But I was really motivated with Charles's obviously expert help to make the whole second half of the book. Okay, so what can we do now? And end with a list of recommendations like an NTSB report. So the analogy we thought was pretty apt, and we stuck to it. And Charles was on board. John Nance is one of the people we interviewed clearly in the book to sort of help us make it work. And it comes together, it kind of reads like a novel in a way. It's a story, right? It's not a textbook. It's not a scholarly, manifesto. It ain't that. It's a story, and it's an incredibly important story to tell. And I'm grateful for Charles's help, and I hope it'll be a bestseller.
It really is great. It's a good read, first of all. It's really good to read it. It's got great stuff because you go from personal stories of your daughter to what's going on at Northwell to, looking at pay-viders and the system itself. And then, of course, you mentioned, as Gregg said before the show, public health. What's
Right.
going on with public health?
What's going on with that?
And how you underfund it. So what would you say are the key takeaways from your book?
Okay. So look, I think our audience for Pop Health Week, these are super smart people, and they've been on the journey like we have for a long time. So none of this is really a surprise. But when you start really thinking about it, okay, so take homes. Are we really going to sit back after 1 million deaths and do nothing different? I mean, that to me, that's the main message. And I see it at all kinds of places, big and small. Like, let's just get back to business and more admissions and fill those beds and do more caths and more cancer and more ortho. And, guys, gals, why don't we ask ourselves the question, what's the real business that we're in, right? I mean, this sounds familiar, Fred. So the take homes are, we got this platform that's an inferno, not just smoldering, but it's totally consumed with fire. Are we going to just stand there, watch it burn, and do nothing different? That's the take-home message, I think. And so are we going to take this once in an industry opportunity to attempt to fix what's broken? Look, I'm running out of time. I've been at Jefferson for 32 years. I'm 67 years old. I could keep talking. Not too many people are going to keep listening. So we're running out of time to make these changes. That's the take-home message.
Right. And I think, as you think about that, David, you've been talking about population health for a long time, and you're still banging that hammer saying, hey, we got to move this direction. And a lot of this are actually population health type approaches.
Totally.
Within your answers of what we need to do. So do you really think the message, and not based on your discussions or the book itself, but I'm seeing, like you said, everybody sort of going back a bit. Are we going to make the move? Are enough of the system people going to make the move to make this happen?
Boy, I'm an optimist, and I'm definitely a glasses half full kind of guy. I don't know, Fred. I'm awfully worried. What I do hope is that one of the best outcomes of the book would be to stimulate exactly this kind of conversation amongst the people who have the wherewithal, the influence, the moral authority to get something done. So let's give some examples, right? So look, there's a lot of great people in medical education, but we're hamstrung by ACGME, LCME, the residency requirements. But okay, somebody's got to put his or her foot down and say, I'm not going to put up with this anymore. We got to train people to become the doctor of tomorrow. Okay, so there's the Bernie Tyson Medical School, there's Geisinger, maybe Walmart will have a medical school. So we got to give those folks a platform. That's one example of the kind of thing I hope will happen. Second thing, yeah, that payvider, that's a clunky term. We were talking about payvider 3 years before the pandemic, right? And all of a sudden now you see integrated delivery systems purchasing or merging or doing a joint venture with a big bad managed care organization, whether it's Medicare, Medicaid, whatever it is, growth in ACOs. Okay, so maybe that's another route. What we do know is you got to go upstream and shut that faucet rather than mopping up the floor. I've been talking about that literally for 13 years, nonstop. So that's another good example. But if the book stimulates the conversation amongst the people who could really make a difference, which I believe is everybody, then we will be successful. And, you got to go back to, I'm old enough to remember, my junior high loose leaf binder, height of the Vietnam War. If you're not a part of the solution, you're automatically a part of the problem. And I just can't be a part of the problem. I got to be out there saying, listen, I don't have every answer, certainly not. But if I could get the right people together to talk about what we got to do, then that's the road to redemption for sure.
So that brings up an interesting idea, David. Could you convene or put some effort in to convene that kind of group? Because I'm thinking from a political perspective, we need to get rid of the 85% medical loss ratio rule. The only thing that does is keep costs going up. There's no reason for a payvider to make people healthy because they'll make less money. And so could you pull that? And you're about to answer that question. Let me let you get to it.
Well, what we hope is in part, and it's a tall order, admittedly, but look, we haven't been together for the PopHealth Colloquium in 3 long years. I'm praying, literally praying, November 7, 8, and 9 will be safe. It'll be great to be back together in person. We're going to have a night set aside, Tuesday night, November 8th, where myself and several other authors of very timely books about healthcare, we're going to have a book seance, to talk about these issues and try to get a groundswell of support. And by the way, it's going to be election eve as well. So holy mackerel, it'll be a high wire act. We'll have televisions. We'll be watching the returns. We'll be talking about healthcare. Fred, our listeners know we are the biggest business in our great country. And whatever happens to healthcare is going to affect the entire country and vice versa. So we got a $4 trillion monster that most people who look at the data would agree 1 trillion of that spending makes no damn sense. Can you name another industry anywhere in our country where that's the case? So that's why venture capital and private equity, why they're pouring money and energy into our field, because they think, wow, if I make a 1% margin on $1 trillion, that's a lot of money. So we could cut that waste. But back to your question, the only people who can reduce waste are the people inside the system itself. That's why I called it the Trojan horse strategy, get inside the system to try to make the change. I really do believe that that's part of what the book is about. And, trying to explain health insurance to Joe and Jane, on Broad Street in Philadelphia, it's hard to do. It's awfully hard. That's why Charles and I wrote, hang in there with us. It's complicated. It may not be bedtime reading, or you got to read it 4 times before you understand what the heck we're talking about. But even so, it's incredibly complicated. But if we start the conversation and get it in the right direction and engage with the right people, I'm optimistic.
Well, that's great. It's nice to have an optimist in the group. I think And I'm looking forward to the colloquium. Obviously, that's going to be one heck of a session. And I'm thinking about this. You just mentioned the concept of an individual, and asking them to kind of manage this thing, which they can't. It's so difficult and complex. But one of the groups you talk about in the book is employers. And you implore them to take control. But again, that's going to require a fair amount of education, won't it?
It sure will. So let's talk about that. I mean, not the first time you and I have even tackled this issue, right? And in our city, we've got my great friend, Neil Goldfarb, the Philadelphia Business Coalition on Health, part of the national movement, doing all the right things, transparency and accountability, showing the leapfrog scores, holding employers responsible while giving them great education. This week's Journal of the American Medical Association, a really great piece on chief medical officers for employers who then are reaching out to guys like you and me. Okay, so maybe we're making some progress, but I would say I'm a pretty easy grader. I would give most employers at best a B- as to how they've managed healthcare costs. It's still all about the brokers. Get me the best price, keep it under control. Give me the biggest network. That's ridiculous in the 21st century. Give me a network that has good outcomes, and give me a network that you could prove that people are following the evidence. They're not being wasteful. They're communicating. They're coordinating. They're not doing stuff they ought not to be doing. I mean, on and on. So do employers do that? I don't really think so. I really don't. I think there are a lot of employers, especially medium ones, who think, all hospitals are about the same and all doctors are about the same. And in Philadelphia, if you don't have all 5 major medical centers in your network, well, no one's going to use it. That's nonsense. And we got to get past that. Awfully hard to do. Awfully hard.
And if you're just tuning in, you're listening to Pop Health Week. Our guest is David B. Nash MD MBA, the founding dean emeritus and full-time faculty as the Dr. Raymond C. and Doris N. Grandin Professor of Health Policy at the Jefferson College of Population Health.
It's going to be. I mean, you think about, I can't tell you how many people I've just talked to personally who say, well, my doctor needs to be in that network. But excuse me, unfortunately, your doctor is in the bottom half. You don't want, and trying to get that message across is very difficult.
Very hard. Look, we all have heroes in healthcare. I have a whole bunch of heroes. Among them, just Atul Gawande, right? Not everybody's equally doing a good job. We know that. And it's a bell curve distribution of performance and outcome. So I'd rather have people at the right end of that bell curve in my network. And I think we have the tools, the technology. What we don't have is the political will to say you're in and you're not. And for the guys and gals who aren't, we're going to give you an opportunity to improve. We'll even teach you how, and we'll give you a shot at getting into the network.
Absolutely.
But some of this, Fred, is vocabulary. When you hear narrow network, right, that's like a war cry, right? That's the wrong word. High performance network. That's the network I want to be in.
And that narrow network came from the 90s when, in fact, they did narrow the network based on price and not quality.
Based on price,
so
right. And then we got to, as you and I have chatted about, what I used to call somewhat disparagingly, any breathing provider. Well, that's a crazy network. Who wants to be in that network? Not me. Right. So employers have a lot of work to do.
For my class, I just did talked about Palm Beach ACO down in Palm Beach County. The number one ACO in the country from savings. You know what they do every year? They drop the bottom 10% of their providers.
Sure.
And those kinds of things, they're tough. And then what you have to do is obviously give the resources to help those providers move back up into the realm of continuing to do the right stuff.
It's counterintuitive that Palm Beach could achieve savings, that's for sure. But if done right, it certainly can work.
It may help a little bit with a high base.
Well, right. But like we talk about in the book, the waste, anybody could cut costs. That's easy. Close a program, close a hospital. Reducing waste, well, that's gut-bustingly difficult, hard work. And that's where doctors, nurses, pharmacists working together with good leadership, with the tools, with the data. And today there's no excuse. There's great companies that could help you get the data and organize it. And every test I've ever ordered, it's all online now. You could see how does Nash do versus everybody else in the practice. Let's get into it. And it doesn't have to be punitive, certainly not. But if you give us the tools and you give us good data, get out of the way. We're going to stampede to improve. That's always been true.
Absolutely. And one of the areas you touched on also is the whole issue of, the disparities, COVID and racism, and what we saw in these various communities. Just tragic.
Tragic. Well, I have to say personally, this was really eye-opening for me. It's one thing to have the College of Population Health and our great journal and the textbook and the colloquium, but to see it in our own city on a day-to-day basis, people dying, the guys and gals who drove the buses, kept the trains going, delivered the groceries, fought the fires. It was a disaster. And when you delve deeper and you see that a lot of these folks never have a paid holiday or barely making minimum wage, they had to show up because they had to eat. And then when they got sick, they went home. The places aren't big enough to, isolate in the guest bedroom. And then all of a sudden, we wonder why communities of color got crushed, not to mention underlying terrible health measures of obesity and hypertension and diabetes and all the rest. It's a toxic witch's brew of poverty, ill health, poor jobs, structural challenges. You put that all together. Well, no wonder that people of color were dying at 3, 4, 5 times the rate of age-matched non-Black, non-colors. It's just unbelievable what happened. And not just in Philadelphia, of course. And this is not a new story. Let's go back to David Ansell's great book, 2017, The Death Gap in Chicago. I mean, this was well described, which is why we say in the book, no surprise, terrible, but no surprise. But speaking personally, to see it in our own town, it really was a eye-opener for me. I didn't really get it, honestly, as much as maybe I should have. But seeing it for that first year, that just was a heartbreaker.
Mm-hmm. And you talked about, that was obviously a huge inferno going on within this broader COVID issue.
Totally.
And you talked about the individuals who ran into that fire and said, we're going to solve those problems. That one case, I think it was, with someone going in with vaccines or something into the...
Yes, Dr. Stanford and others. I give the Jefferson leaders a lot of credit. I was super proud of the day-to-day amazing folks who were in charge, some of them now gone, but who were on the front lines of organizing our response. It's awfully hard. There was no infrastructure, no way to keep a record of who got a vaccine and who didn't, and where should we go, and how do we talk to people who don't trust us at all, and how do we treat people when there's no doctor who looks like them, and all of that stuff came to a head. Oh, and then of course, murderings and the Black Lives Matter movement and the riots all at the same time. It was unbelievable confluence of these events. And then even corny stuff like deputy editor of JAMA saying, well, there's no structural racism because doctors aren't racist. Well, okay, that was like the final, that gave me insight that no, we just don't get it. And then you realize that if that's the status quo and that's the leadership, we got a long ways to go to sort this out. And I'm not Pollyanna. I'm really not. But I am realistic enough to say, well, we got to have a different approach. But if you're going to get paid to do more, that approach will not work to keep people healthy. It's not going to drive the creation of more primary care centers. It's not going to get into the toughest, poorest zip codes in a city like Philly. It's going to take outside resources. Hence our project with Novartis and Closing the Gap and other related activities. But this is a drop in the bucket compared to the greater challenge of the healthcare system is the final common pathway for all of the social determinants, right? When you look at it outside looking in, the poverty and ill health all come together in, creating the need for healthcare services, and diabetes out of control, obesity, cardiovascular disease. We're the final common pathway for all of that. So it'll take a societal change in saying, what's the core business that we're in? If the core business is improving health, okay, well, let's organize to improve health. But I would argue we haven't even had that conversation. What's the core business, and how are we going to get paid to implement the core business? Not trivial. And we try very hard to raise those questions in the book. It's complicated.
It's very complicated. So, David, you mentioned Atul Gawande, and obviously we had the news about Amazon acquiring One Medical. Is that Haven 2.0? Is that a VC play? What is that?
Yeah, good question. I hope it's not Haven 2.0, with all due respect to Atul and the team. Well, look, it's not unexpected. Amazon has been nibbling on the edges, right, with PillPack and other opportunities. And Alexa, I wrote a piece, Alexa, refill my omeprazole and have it delivered, and bring some recipes on low reflux diet, right? So I think it's, to me, a step in the right direction, because it's going to be disruptive, and that's great. And it's going to put the provider community on notice that this is just the first of many salvos across the bow of this boat. That stuff is not going to remain the same. And I'm looking forward to see, and I wish them well.
Thank you so much for coming on. The book is great, How COVID Crashed the System. It's really a good read. But it also, as you said, it has great ideas on what we can do to begin to try to fix the system. So I really appreciate your efforts in writing this and putting the time in. I know that was a lot of work.
Well, thanks so much. Great to be together. And I hope we'll see everybody November 7, 8, and 9 in Philadelphia.
Absolutely. Head to the colloquium. It's the place to be. And with that, thanks again, David, and back to you, Gregg.
And that is the last word on today's broadcast. I want to thank our special guest, David B. Nash MD MBA, the founding Dean Emeritus of the Jefferson College of Population Health, for his time and insights and preview of his new book, How COVID Crashed the System. Do follow his work at Jefferson via @jefferson.edu/population-health, and on Twitter via @NashPopHealth, and the college via @JeffersonJCPH. And finally, if you're enjoying our work at Pop Health Week, please like the show on the podcast platform of your choice, share with your colleagues, and do consider subscribing to keep up with new episodes as they're published. We stream live on Healthcare Now Radio weekdays at 5:30 a.m., 1:30 p.m., and 9:30 p.m. Eastern. And for you left coasters, 2:30 a.m., 10:30 a.m., and 6:30 Pacific. For Pop Health Week, my co-host Fred Goldstein, this is Gregg Masters saying, please stay safe, everyone. Bye now.